Hi, I'm Nancy Reau from Rush University Medical Center, and I'm joined by my wonderful colleague, Joseph Lim from Yale. And we are really excited to give one of the live case reviews where you are supplying cases to us, and we're going to help navigate some of these complex hepatitis C cases. Although hepatitis C has been simplified over the last few years, there are still some challenging questions. And so whether you're a new treater or whether you're a very experienced treater, we're really excited to help you navigate this process. So this is me from Rush University and Joseph Lim, who's a professor of medicine at Yale. All right, learning objectives. Upon the completion of this activity, a participant should be able to, number one, discuss the impact of comorbid and co-infections on management of patients with hepatitis C. Number two, select appropriate regimens to cure patients with hepatitis C infection according to the AASLD IDSA recommendations, which are always changing. So always go to the website because they could be new. Determine appropriate management approaches for the liver-related complications in hepatitis C reinfection in patients who achieve a sustained virologic response, which is essentially a cure. All right, I'm going to start us off with our first case. So this is a hepatitis C treatment-naive 22-year-old woman. So she comes for a routine annual checkup. She has no idea that she has hepatitis C. She has no symptoms other than a little bit of malaise. And on some prompting, she does confide that she thinks that she might be pregnant. She had skipped a period. She does admit to some high-risk activities, occasional drug use with cocaine and marijuana, not fentanyl, which is like the current drug of choice. She does this mostly on the weekends. She does not consider herself an addict. She had a resolved COVID-19 infection about 6 months ago. And at that time, had fever, sore throat, all those typical things. And this did resolve. She had no need for infection and for hospitalization. And you can see here on the side, she doesn't smoke, but she does occasionally drink. And again, we already talked about her drug use. She's working from home and she has been recently married. So the first question that we'll poll you on is, would you test her for hepatitis C? And don't be biased. Just because this is a lecture on hep C does not mean that that's the default answer. So if she had walked into your office and you would have tested her for hep C, please answer yes. Answer no if you would not have. And if you're unsure, that's a very valid answer. Joe, which of these factors made you worry that she might have hep C?
Well, I think that it's very important that remember that the USPSTF, the United States Preventive Service Task Force, and the CDC do strongly recommend upfront, regardless of other factors unique to this patient, that consideration should be given for a one-time antibody test for hepatitis C. For her specifically, she obviously has risk factors in terms of transmission, as well as individuals who are childbearing age or those who are pregnant get special prioritization for screening. And so I think that it's very clear that in this case that she would absolutely qualify for hepatitis C testing.
All right, so Joe's been cheating because he's a hepatologist, but correct. Although she does have risk factors, irrespective, if she had said she had no risk factors, she still has a risk factor because she happens to be between the ages of 17 and 79. So this is a nice demonstration in graphic form of the CDC, AASLD, and then the United States Preventative Task Force recommendations, and the USPSTF allow you to actually get reimbursement for testing. So everyone between the age of 18 and 79 should be considered for hepatitis C testing. And then those on the fringes, if they have high risk factors such as active injection drug use or exposure to someone with hepatitis C, they should be additionally tested. Everyone else, though, should definitely be considered for at least one hepatitis C test. Now, there's an additional layer to her. She's afraid that she might be pregnant. So although she didn't present for that, we don't know exactly what she presented for, whether it was a well visit or whether it was a well visit because she thought she might have something that was in addition to that. With the screening guidelines have now endorsed hepatitis C testing with each pregnancy. This is in addition to the hepatitis B testing that is already done. And this was early advocated for by the AASLD and IDSA, but later gained traction by CDC, United States Preventative Task Force, and more recently, as in the May, the American College of Obstetrics and Gynecology. Okay, I'm a GI person at heart, and then maternal fetal medicine. And this was hard. This was a big debate between these societies because they don't feel comfortable screening and considering the options of treatment. And it's a conversation that they didn't necessarily want to have. But the case for this, which is in that blue box, is that we recognize that hepatitis C incidence and prevalence is now bimodal, so that there is a big increase in younger demographics, and this includes women of childbearing age. Because not every person is going to be forthright with their risk factors, and more importantly, it's a great opportunity to test someone at a time when they do not have advanced disease, and then link them to curative therapy, which then would mitigate any risk of transmission. This is a very, very opportune time to capture a demographic that otherwise would not necessarily be screened. It does require a little bit of knowledge, so that you want to make sure that your OBGYN colleagues feel comfortable in why someone will be screened, and make that linkage very easy. But this, I think, is a very important time when we can consider therapy in groups that otherwise might have been missed. All right. And although this is a very complicated sign for something that's actually fairly easy, screening is with a hepatitis C antibody test. I've found that the one thing that has been an advantage for the COVID pandemic is that people now actually know what antibodies are. They kind of understand what a virus is. And so this conversation has been ever so slightly simplified. Most of our labs actually do an antibody that automatically reflexes to hepatitis C PCR, or that confirmation test. If your antibody is positive and your PCR or your viral load is negative, you have been likely exposed to hep C, but you've either been cured through therapy or it's spontaneously resolved. If the PCR is positive, then you have active hepatitis C infection, and you want to be linked to care for consideration of curative therapy. So our patient is really a little bit concerned about this. So she's screened and she wants to know, if this is positive, does this mean I have hep C? She wants to know what a viral load is, and if it's really high, is that going to be worse? And so, Joe, what do you tell these individuals who entered into the system not even talking about hepatitis C? She's probably a little more worried that she was tired and could be pregnant. And now you're hitting her with something that is going to be potentially stigmatizing and might make her afraid about the safety of her pregnancy.
Yeah, absolutely. That's a great question. And I think we have to remind ourselves that, especially in individuals who are going through pregnancy, they're going through remarkable changes in terms of their health and physiology. And they are worried not only for their own health, but for that of their child as well. And so we want to be as sensitive as we can in how we communicate what the implications of hepatitis C positivity means. Fortunately, we recognize that the hepatitis C antibody being positive does not equate chronic infection. We know that among individuals who are exposed and infected to hepatitis C, that somewhere between 15 to 40% of patients will spontaneously resolve their infection. And as such, we need to make sure that we do go ahead and confirm whether or not they are in the group with chronic infection with the viral load or the RNA. It turns out that particularly among young women, epidemiologically, we know that the proportion of patients who actually have spontaneous resolution appears to be a little bit higher than for other groups at the time of infection. And so I think we can reassure her that although it is possible that the hepatitis C may actually represent infection, there's a chance that it may not. But the second point, though, is that even if the hepatitis C is positive, we can share the fact that there is a cure, right? And I think that that is something that is no longer viewed as a death sentence for patients, because we now have a highly effective, easily tolerated pill-based therapies that have cure rates over 90%. And so I think that a lot of this comes through just sensitive delivery of this information and clarifying what it actually means for her.
So we know that most providers that treat or screen for manage hepatitis C are pretty aware that fibrosis testing is important. And I think that this is a very difficult concept to translate to patients. And so if she was in my office, I would have probably, independent of pregnancy, recommended that we do a FibroScan or consider some type of fibrosis assessment. And this has generated a couple of additional questions for her. So she wants to know if fibrosis means that she's going to die. And really, I think she's asking, do I have cirrhosis? How do you broach this with your patients?
Absolutely. So I think that's one of the most important questions that we must ask when we initially diagnose a patient with hepatitis C is, do they have cirrhosis or not? Do they have any significant liver fibrosis? Because this has implications not only for the treatment itself, but also in terms of the post-treatment management. I think that it's intuitive that patients who have cirrhosis do bear a higher risk of complications, whether it's liver cancer, liver failure, et cetera. And those who have milder disease oftentimes have a normal lifespan post-cure, right? And we'll come back to some of these concepts later in our discussion. But in terms of the fibrosis testing, I really frame this as one of the most important things that we do to know where they stand in terms of liver disease before we consider treatment. And my approach personally is to do 2 non-invasive tests. I usually use a FibroScan and a serum test. And the reason why I prefer 2 over 1 is simply that the test performance for any one test has intrinsic error. And if 2 tests have alignment, let's say stage 1, I have got higher confidence. But in cases where one shows stage 3 and stage 1, then I may need to go further and to verify where they stand, because it matters, because it directly impacts our management. I'm curious how your approach is.
No, I mean, very similar. At 22, I probably would have been confident to do a FIB4 and then a FibroScan, because the risk of advanced fibrosis is pretty small in a young person. If she was older and had mild, borderline platelets or something that made me a little more concerned, then I would probably do something I had a little more confidence in, whether that's a FibroScan with a something like a FibroSure or a panel of non-invasive markers that were a little more specific, or even an MR elastography. But I do agree with you. I think that this is the one place where we can help people know that with cure, they're either going to return to be a general population, which is still at risk for alcohol use disorder and fatty liver disease, not immune to the world, or whether they need to be monitored in longitudinal care. Well, I will move on here. I think that most of us are very familiar with what the results mean. If your antibody is positive and your RNA is positive, you have disease. If the antibody is positive and the RNA is negative, then you likely have either cleared through spontaneous resolution or through therapy. And if your antibody is negative, I don't know why you had a PCR. It was because your physician or your clinician likely was very worried about you. But this could be early acute infection. And we often will screen our patients with PCR when they present, and we know that they've engaged in something high risk, and we're really very concerned. Otherwise, it might be a false positive, which is pretty darn rare. And then negative, there's no risk of hepatitis C at that point. So to keep on going, she has a pregnancy test. She is pregnant, but she also had confirmatory testing that led to a positive viral load, although genotype arguably is not necessary when you're considering treatment choices, because all of our treatments that are first line are essentially pan-genotypic with a few exceptions. ALT and AST are done. We can talk about that a little bit more, but you want to really make sure that you have some understanding of what her liver status is right now. And they are both elevated. AST is a little higher than the ALT, which makes you think that maybe the alcohol use is a little underestimated. Hopefully she's not drinking and that she knows she's pregnant. And then she has testing that assures us, as we expected, that she doesn't have significant fibrosis. So she wants to know what's next, or we want to know what's next. Would you choose to monitor this patient? Would you begin therapy now or at some point soon? Or again, unsure? And we'll go to those polling questions. I think that a lot of what you do next, and Joe, I'll see what your opinion is, but it depends a little bit on the patient. You're never going to want to do something other than monitor her. You're not going to be like, oh, don't worry about this. We'll think about this in 10 years. But I I have been a little bit more willing to consider therapy during pregnancy if I have a woman that's really interested in treatment. Now, most pregnant women in my experience are even hesitant to take a multivitamin. They're very worried about things that might impact the health of their child. But I would not be opposed to that. Joe?
Yeah, I share the same viewpoint on this. I think that, frankly, I think because hepatitis C typically is an indolent infection with relatively slow progression over time, there isn't immediate urgency to treat hepatitis C in most cases. And so in someone who's 22 years old, likely with modest or mild fibrosis, particularly in context of pregnancy, I have not been in the position of treating, particularly during pregnancy. The only exception actually has been when the hepatitis C is causing severe complications, such as extrahepatic manifestations, like cryoglobulinic vasculitis with kidney disease. That's probably been the only scenario where I definitely absolutely would prioritize treatment in this context. But in general, I agree 100%. I generally will keep a close eye on this patient and make sure that we have good follow-up after pregnancy so we can proceed with treatment as soon as possible.
Yeah, and our audience was also a little bit, undecided. No one was actually unsure, but when we looked at them, some would monitor and some would actually have initiated hepatitis C therapy. And again, that's not wrong. I want to emphasize that there are not right and wrong answers in these cases. Well, one of the most important concepts is that this is going to affect all of us, especially if we see young people, we see people who are of childbearing age, and if we manage people during pregnancy, because there is a significant increase in hepatitis C in women of childbearing age, which is strongly associated with the opioid epidemic and injection drug use. And you can see from this graphic, which ended in 2014 and unfortunately has continued to go this direction, that there's a strong increase in this younger demographic. So what does the AASLD IDSA say? So our guidelines or our guidance documents are always just guidance documents. And so they try to be as comprehensive as possible and set the stage for standard of care, but they don't always help you navigate the individual sitting in front of you. So the most important thing is that they emphasize that you should really do some assessment of liver function and make sure that the virus is active. So if you have an antibody without a positive PCR, that individual is essentially the same as any other pregnant woman. And there was a recent AASLD abstract that kind of confirmed that. The Ontario group looked at hepatitis C antibody positive patients that were PCR positive versus PCR negative. And the PCR negative individuals really performed a lot more like women that had never had hep C at all. So you don't want to miss cirrhosis, and you want to make sure you know that your patient is viremic. Outside of that, there is no known way of decreasing maternal childhood transmission or mitigating any pregnancy-associated complications of hep C, which are few. So hep C is very well tolerated during pregnancy, but it does seem to increase slightly the risk of intrahepatic cholestasis. And so I think that if you have a woman who's gotten pruritus and you're worried about ICP, you need to think two things. Number one, test them for hep C. And number two, if they have hep C, recognize that the hep C is likely contributed. This means that even if you should not treat them right now because of the ICP, you want to make sure they're cured between pregnancies, because intrahepatic cholestasis of pregnancy can return, and anything you can do to decrease that risk is going to be important. If they have cirrhosis, which is not 100% negative. So we used to say that cirrhotic individuals could not become pregnant. Cirrhotic women could not become pregnant. We now recognize that if you have a well-compensated cirrhotic, their hormonal function is exactly the same as if they did not have cirrhosis. It's only our decompensated cirrhotics that have infertility issues. And so they still could have cirrhosis, and then they want to be linked to maternal fetal medicine that's associated with high risk. And we try to do that upper endoscopy to ensure they don't have esophageal varices. There are also other implications. You want to make sure that you're looking at the children. So maternal to childhood transmission is low. We'll go through a little more data on that, but it is not zero. And so we need to make sure that the infant is tested for hepatitis C. Now, our testing recommendations are challenging. And I'll ask Joe when we finish this slide, because in in adults, we know that the care cascade has some huge gaps from antibody testing to confirmation PCR. There's a big gap there, so much so that we now reflex test. And yet in the algorithms for children, we're recommending that at the time of birth, when you know that the woman has hepatitis C, you don't test the child at all until 18 months. If you do test by a PCR test, it should be somewhere after the age of 2 years, but there is no recommendation. And even if it is positive, you need to recheck in the future, technically around 18 months or after, before you would initiate therapy. And so there's a lot of gray in testing and linkage statements for your children that are born to hepatitis C positive mothers. We do know that there are hepatitis C available treatments down to the age of 3. And so it really pushes a lot of the thought process until the age of 3 or beyond, when you not only can demonstrate maternal to childhood transmission, but also have options to talk about for treatment. The other thing that's important here is that if you have a sibling to a child born to the same mother, they should also be tested. And when we define children, we usually think of little people, right? We're talking about 2 months, 18 years, but we expand that. And again, this is another thing that I would like to hear Joe's comments on. If I have a woman who's 70 who tells me that she had a transfusion with her first pregnancy and she has 7 children, so 6 after that, I recommend that her children are tested. I think that children born to hepatitis C mothers are not just infants. They are truly children. And although it's easy with the now broad definition of 18 to 79, you want to really try to get those individuals that are potentially exposed in a very unassuming way, a link to testing much earlier. So before we move on, Joe, any comments on that?
Absolutely. Yeah, this is a really important content here that you're sharing, because this is something that we get asked a lot of questions, particularly from the hepatitis C infected mothers. I'm probably similar to you. I have a lot of mothers who are very concerned about their children, and they want their kids tested multiple times. And of course, we're treating them, not their child. But they're often asking many questions about when they can be tested. And I usually suggest that they have to be somewhat patient, because I think the key message is that antibody test is not going to be reliable in the first year. The antibodies will be reflective of the mother's hepatitis C rather than that of the child. And so if they're going to do it, I absolutely recommend that RNA be used, especially within the first 12 to 18 months. But in regards to siblings, I have to say is that I'm not nearly as good as you are in terms of being really reminding our patients to have their family members checked. I routinely suggest to my patients that they should have their spouse, their partner, their children to be tested, and when appropriate, their siblings. But I certainly don't recommend that as strongly as perhaps we really should, because if we're really going to identify the infected patients that have been missed from our current screening modalities, we're never going to eliminate hepatitis C. And so I think this is a really great opportunity for us to find more of those patients.
Thank you. So this is a little bit more of a summary, but women of reproductive age with known hepatitis C should be counseled about the benefit of DAA therapy prior to pregnancy. So ideally, you want to treat them before they're pregnant. Maternal to childhood transmission is low. I think we have some more granular slides in a moment. And antiviral therapy is recommended before pregnancy, but can be used during pregnancy if it's the best risk-based recommendation. And as Joe already outlined, you would really want to consider treatment if you have a person who's got, cryoglobulinemia or nephrotic range proteinuria, something that you think is an extrahepatic manifestation that really would respond to treatment and cannot be deferred until after the postpartum period. There are no large-scale clinical trials evaluating the safety of DAA therapy in pregnancy. That being said, that there are some trials looking at sofosbuvir lidiposphere in pregnancy, and it's been, reasonably effective and safe. And there are some growing data on soft-bell. The other therapy, which would be called capavir pibrentosphere, that is readily available, does not seem to have any animal models that would suggest that there would be big pregnancy signals. But that company, as most companies, does not have a strong emphasis on looking at the pregnant population specifically. I already summarized just a little bit that pregnancy's impact on hepatitis C is relatively low. We do see some fluctuation in ALT, AST, and viral loads, as you would expect with that immune tolerant idea of pregnancy, but we don't think that the hepatitis C impacts pregnancy significantly, and pregnancy does not seem to make hepatitis C more severe. And this is just a summary of multiple slides looking at the risk of transmission. It is much higher in our HIV positive mothers at 10%, but in the HIV negative mothers, it's about 5.8% by this cumulative study. And when we think about the AASLD, there was that same Ontario study did show that viral load seemed to have some predictive availability, but they did not have it was the cutoff for viral load was relatively low. So most of the mothers would have a viral load above that cutoff. And that alone would not be a reason to engage in treatment to prevent maternal to childhood transmission. All right. So she's now ready to start therapy. So fast forward, she's following up 2 years after giving birth. So she met Joe, and he had talked to her a lot, made her comfortable that she could have this pregnancy, without event, despite her hepatitis C. And as a reminder, she's a genotype 1A, which we shouldn't have to update even with our most conservative insurances, but her hepatitis RNA is reevaluated. I will come back to that a little bit because our guidelines actually state that we should retest the viral load after pregnancy in our women because there's a risk of spontaneous clearance. I have not seen that. Now, I do not have a large group of nothing but pregnant women, but of the women that have been identified during pregnancy of having hepatitis C and have been linked to care and have seen me, I have not seen a single one that had spontaneous clearance. But I'll let Joe comment if he's seen that. ALT and AST are still elevated. She is still low fibrosis, and she is now on a combined oral contraception. So that's in general a progesterone and estrogen containing product. And you can see that although her relationship is now recently married, it's now 2 years plus recently married, but she's ready to engage in treatment. So thoughts? Do you delay treatment for 6 months, or would you treat her now? And while we go to this polling question, I'm going to have Joe come back to that idea of spontaneous clearance.
Yeah, that's just a really important point that you raised, because after someone is tested positive for hepatitis C based on antibody and viral load, there is a natural tension that you want to get that patient treated as soon as possible. But the natural history studies do suggest that there is a small proportion of patients who will resolve their infection beyond the initial 3 to 6 months of the acute infection. But that number is pretty small. And I think that typically if you followed the patient for a year or two, in this case you had 2 years, I don't think that there's much indication to wait further, and I would go ahead and treat. Now, I think that the related issue, of course, is not outside the setting of pregnancy. Would you treat acute infection within the first 3 months? And I'll get us off a huge other topic, of course, but my inclination, honestly, is that if I have that patient in my office, I don't want to create any barrier to treatment if that patient is ready and willing to undergo therapy, recognizing that there is probably a small percent of patients who may resolve on their own.
Excellent. Yes, I think that a lot of the retesting and the delay stems from when we had more toxic therapies, and it's made us a little hesitant. Should not give treatment that's not necessary, but the risk-benefit ratio really weighs for early initiation of treatment, not necessarily during pregnancy, but early initiation. And I think that our poll really felt that at this point in time, there was not any reason to delay therapy, so that they were all gung-ho to treat. So what would you treat with? And so this is just a reminder that although pregnancy and infancy are two places where therapy is not approved, there's a lot of overlap in the other aspects. And so her child is 18 months, I think, by our other slide. The average woman is no longer breastfeeding at 18 months, but sometimes you do have very very invested mothers that are, have prolonged breastfeeding, and breastfeeding is not a contraindication to treatment. Outside of that, at this point, our woman really falls nicely into any of the areas where we would consider that we have approved therapies for effective treatment. What can we use? In theory, we have 4 first-line therapies, or at least 4 approved therapies: glecaprevir, piperacillin, and sofosbuvir, velpatasvir being our all genotype, treatments that are probably the most frequently used. She is a genotype 1A, so you could still consider ledipasvir, sofosbuvir for 8 weeks with her. And elbasvir, grazoprevir is still an option at 12 weeks for her. At a 1A, in theory, you would be checking for resistance associated mutations, but I think that treatment option is much less utilized. But rather than what you're going to use, because probably her insurance will dictate what you have access to, it's the drug-drug interactions that you need to consider. So you don't want to give her glecaprevir, piperacillin if she's on an estrogen-containing agent. You don't also want to stop her birth control, start her initiate her on Hep C therapy, and then find that she gets pregnant. And so you have to either adjust her birth control management or use a therapy that is not glecaprevir, piperacillin before you would initiate treatment. And this is not impossible to work around. You can see from our list of things here that there are still options that are very green. A lot of my patients, especially if they're not intending an immediate pregnancy, will just use an IUD rather than oral therapy. But there are many ways of adjusting around this. Joseph, would you have just let her continue her birth control and pick an alternative agent?
I think a lot of it depends on the individual situation for this patient and whether there are real reasons why this particular regimen was needed. But in general, I try to treat with the best available regimen that does not require a switch. But I think I agree with you. I think in case that the patient is taking any of these OCPs that are marked in pink, I think that's a clear warning. And I think both from a clinical perspective and medical legal perspective, I think we want to do everything we can to educate our patient about what's the right choice for the patient. I agree with your approach here.
Yeah, but the wrong answer would be to stop her birth control and just treat her. You still want to make sure you have pregnancy planning. All right, I will turn it over to Joe now, who will walk you through a non-pregnant woman.
All right. Thank you, Dr. Reau. So I'm pleased to present case number 2. So this is a 6-year-old male with diabetes type 2, hypertension, and congestive heart failure, and in fact has been recently hospitalized for CHF exacerbation. Does have some medications that are being used to treat these conditions: metformin, Lasix, spironolactone, and amiodarone, and has a history of a prior lap chole. We further have evaluation for abnormal liver enzymes, which is the indication for the referral to your office. And in this part of this evaluation, you discovered that he has hepatitis C and is confirmed furthermore to be genotype 1 with a viral load of 1.2 million IUs per ml. You perform an examination and find that the liver and spleen are enlarged, suggestive of the possibility of cirrhosis. Although there are no evidence of ascites, pulmonary erythema is identified, signaling the possibility of cirrhosis and portal hypertension. The ultrasound that you perform, again, no ascites, but does have nodularity, suggestive cirrhosis. And unfortunately, to your surprise, you find that he has a 2.22 centimeter mass lesion, which raises a concern for possible liver cancer. You then proceed with a dynamic imaging study with a triple phase CT scan, which confirms that this mass is compatible with the diagnosis of hepatocellular carcinoma based on a classification of Lee-RADS 5. Although beyond the scope of today's discussion, Lee-RADS 5 usually is associated with radiographic features that are highly compatible or basically diagnostic for liver cancer. You then go ahead and do a screening endoscopy because of the diagnosis of cirrhosis for the presence or absence of varices. And you confirm that small grade 1 varices are identified. And what this suggests is this patient has cirrhosis with clinically significant portal hypertension and a new mass lesion suggestive of liver cancer. On the right, we get a little bit more detail about the laboratory profile. Modestly elevated LFT is about 2-fold upper limit of normal. the bilirubin is borderline high. The kidney function is borderline abnormal as well, by 1.5, suggesting the MELD score may be slightly elevated. The albumin is technically normal, but kind of on the borderline low side. Alk Phos is actually high as well, and that may actually warrant further investigation just to make sure that there isn't something else going on beyond hepatitis C alone. The CBC is unremarkable except for the presence of thrombocytopenia with a platelet count of 74, compatible with hypersplenism. You screen for hepatitis B, and the surface antigen is negative. And finally, AFP, which you do for HCC surveillance, is borderline high with 32. But remember that even among patients with confirmed liver cancer, up to a third of patients may have normal serum AFP and therefore cannot be used alone for HCC surveillance. Now, the question here for the audience response is the following. Which management approach would you address first for this patient? Would you stabilize the liver cancer first? Would you go ahead and treat the Hep C preferentially? Would you treat both at the same time? Treat the Hep C, treat the HCC, or are you unsure?
I'm glad this patient was in your clinic, Dr. Lim, and not in mine. I'm just dealing with pregnancy. So although the vast majority of patients are simple to treat, we really want to emphasize that most of our individuals that have hepatitis C walk in, and even with compensated cirrhosis, they don't have a bunch of comorbid conditions that make things challenging. But then every once in a while, we do have a diagnostic dilemma. And I think that this patient nicely demonstrates that you have a bunch of things you have to prioritize. So when we're talking to our fellows, it's a matter of ranking the things that you need to address. And sometimes the thing that seems the most obvious, like the hepatitis C, is not the thing that you need to address first. And so I think making sure you're not missing something else, if this person's alkaline phosphatase was from severe congestive heart failure with an EF of 5%, maybe the cancer and the hepatitis C are kind of irrelevant because the cardiovascular risk is going to be so much higher. If it's something that's very easy to control, then suddenly the liver-related priorities become more paramount, and then you want to figure out how you can help this patient most effectively navigate his complex history.
Absolutely. That's really helpful because I think that the clinical context of the patient overall is going to really help to guide your approach to management, particularly when you have competing priorities here. And I think that that's reflective of the diversity of responses here. What we saw here is that the most common response was to stabilize HCC first, about 40% of respondents. And the next most common was to treating both HCC and Hep C at the same time, and a very small proportion to treat the hepatitis C preferentially. So let's go on with a few slides that help to answer some of these key questions, which is what are the implications of liver cancer on Hep C and Hep C therapy? This is a large cohort study from the National VA system, about 17,000 patients treated for hepatitis C. And they're divided into three groups. First is those who don't have liver cancer, have never had liver cancer. The second, with any history of cancer, either active or prior. And number three, those who have a history of liver cancer and have successfully undergone liver transplantation, and they're being treated on the other side, post-transplant. And what the question is being raised is, are there differences with regards to sustained biological response rates between these groups? Importantly, there are some meaningful differences in baseline characteristics between these groups. Naturally, those without cancer generally are less likely to have cirrhosis than those with cancer. And then similarly, for those with HCC post-transplant, generally speaking, they don't have cirrhosis because they've already been transplanted and they have a new organ. So what are the results? And so although we won't walk through each of these lines here, I do want to highlight on the left bar overall results, which is that in the purple group, this is looking at those without liver cancer. The baseline risk or chance of SVR rather is around 90% or 91% to be precise. If you look at those who have a history of liver cancer, the SVR is presently low, substantially lower, and was found to be statistically significant. It's 91 versus 74% with an adjusted hazard ratio of 0.4. That's a pretty significant difference in SVR rate. And among those with HCC but underwent liver transplant, their SVR rate was basically equivalent to those who never had liver cancer. But the message is clear here, is that our cross genotypes, and even after stratification for baseline cirrhosis, yes or no, that there is a difference in chance of SVR if you have liver cancer or a history of cancer. Let's look at a different study that answered this question in a different way. And this is the HCV target cohort. This is a multinational prospective obstetric cohort study. They had about 1,500 patients, and they similarly stratified patients in 3 groups that were slightly different. First, similarly, no liver cancer at any point in the patient's history. The second group are those who have liver cancer that's completely treated. And the third group with liver cancer that's untreated or partially treated. And the question is, are there differences in SVR between these groups? So what were the results? So similar to the VA cohort, the baseline cohort without any history of cancer, SVR rate of 91%. That's what we would expect. I would then highlight the third column, which are those with active liver cancer. They're patients where they're either untreated or they're only partially treated. In other words, they still have viable tumor. And similar to the VA observation, the SVR rates are quite low, about 80%. And this was found to be statistically significant with an adjusted odds ratio of 0.5. And so I think the message is clear that if you have active liver cancer, SVR rates are lower. Now, how about if you treat the cancer? What we see here in this cohort is the SVR rate does go up a little bit into the intermediate range between the 2 groups, suggesting that if you wait until the HCC is treated, is possible that the SVR rate may be higher than if you treat in the context of active tumor. So why in the world would active liver cancer cause the SVR to be lower? We won't go through all the details here this evening, but I just want to highlight 3 hypotheses. First is that the tumor cells may actually serve as a reservoir of hepatitis C, and that there's an impact on intracellular transport of the HCV that may evade the antiviral effect. Number 2 is that the tumor microenvironment may actually alter host immune response to hepatitis C. Now remember, going back to the interferon days, that after you suppress the HCV RNA in a profound manner, either with interferon or DAA therapy, that you still need host immune response to clear infected hepatocytes, especially from reservoirs of HCV in extrahepatic locations. And so to the degree to which this is true, HCC may actually alter the host immune response to clear infected cells. And then finally, this may actually directly impact drug metabolism, drug distribution to tumor cells versus healthy normal hepatocytes. Collectively, these are 3 reasons why liver cancer meaningfully decrease cure rates. So this then raises the question, what is the approach that we should take in approaching hep C therapy in those with a diagnosis of HCC? So first is that if the HCC is considered curable, I think that most individuals and experts agree that treating liver cancer is of the higher priority. And so you want to treat the HCC aggressively, particularly in context of the fact that the chance of cure of the liver cancer is dependent on timely therapy of the liver cancer. You do not want to delay treatment of HCC. And furthermore, there is a secondary rationale, is that if you treat HCV in the context of active tumor, perhaps the chance of cure also may be lower. So how long do you wait? I think there is some variance in opinion, and I'll be going to Dr. Reau shortly to ask her opinion on this, but many will suggest that waiting up to 3 months after treatment with the tumor may be reasonable before treating the hep C. Now, if the HCC is considered incurable, advanced multifocal metastatic HCC, stage 4, then I think that although you may want to consider aggressive treatment for palliative purposes, the question is raised, what is the goal of HCV therapy? Is it really going to meaningfully alter the natural history and the prognosis of that patient? And thus the question, is it worth treating hep C at all? So I'm curious, Dr. Reau, so what are your thoughts on this, and how do you explain this to your patients?
Yeah, I think that patients are usually pretty accepting to have their cancer stabilized before they undergo hep C therapy. And when you start to go through most of the local regional treatments, the first look to make sure your local regional treatment worked is usually about a month later, and then 3 months after that. And so I think it's kind of natural for me to tell the patient, we're going to see how you're doing after a month. And then in a couple of months, if you're doing great and your tumor is still stable, we'll start the hep C treatment there. And so I think that 3 month post, stabilization is a good point. Now, is it the perfect point? I don't know. But for me, it's an easy thing so that we don't lose track of things and the patients are getting, close follow-up. For the advanced HCC, I have treated patients that did not fit into criteria for systemic chemotherapy. So our oncologists are sometimes hesitant to treat someone who's got a bilirubin above 3 or whatever their defined guideline is. And I have sometimes engaged people in hepatitis C treatment to see if I can improve their synthetic function to make them eligible for systemic treatment. Now, that is not in the guidance. That is not always a good idea. And remember, in someone who's got advanced disease, you cannot use a protease inhibitor. But here, it's somewhat of a palliative approach. We're just trying to give them an opportunity to consider some type of systemic chemotherapy. I mean, our biologics now are actually fairly well tolerated, even in advanced disease, if you can just make them treatment eligible.
Absolutely. So as you can tell, as Dr. Reau has highlighted very eloquently, some of these cases can be quite nuanced in terms of how you approach this. And so I think that in these cases where you have a case with advanced ACC, involvement of either transplant center or a expert clinician will be particularly important to consider to help bridge that gap. I'll only add one thing, which is obviously in the context of someone who's under consideration for liver transplant. There are data suggesting that treating the hepatitis C can cause the MELD scores to actually improve a little bit, and proverbial purgatory, MELD purgatory, where you may actually disadvantage that patient for getting organs with a lower MELD score. And so the point, though, is that every patient is different, and I think we need to. It's our duty to offer them all the options and to talk them through the implications. So let's go on to our next slide here. So in this patient, I think that the clinician decided that treating liver cancer was the higher priority. And so he underwent transarterial chemoembolization, or TACE. And good news, 1 month later, dynamic imaging study confirmed that the tumor was fully treated and had non-viable tissue. So great news. So the question that is then raised is, what is the implication of DAA therapy after complete response to liver cancer? And so I think it's very clear that DAAs are associated with improvement in long-term outcomes, not only just in terms of trying to reverse fibrosis in those who are non-cirrhotic at baseline, but among patients with cirrhosis, we have clear evidence that you can improve liver enzymes, liver function, the synthetic function, decrease portal pressures. Some patients who are decompensated sometimes can recompensate or have decreasing diuretic requirements, etc. MELD scores improve, bilirubin improves, etc. And furthermore, there are some data which show that we may potentially reduce the risk of late HCC recurrence by treating the virus, particularly if we believe the virus is meaningfully contributing to tumorigenesis in that patient. So I think the question is not so much whether we should treat hepatitis C in most patients with liver cancer, but simply one of timing. And so I think that it's pretty clear that there is some prudence to waiting at least 4 to 6 weeks to confirm that the patient, in fact, has been adequately treated for liver cancer. If this patient's MRI at 1 month post-treatment suggests that there's still viable tumor, or even worse, that there was further expansion of tumor, additional lesions, then I think that the treatment still would focus on treating the tumor, right? Treating the liver cancer, and then further delaying the DAA therapy. I think that is particularly important just to confirm that there has been appropriate response to the local regional therapy before we pursue DAA. So the next question for our audience, now that the liver cancer has been stabilized, which DAA regimen would you prefer in treating the hepatitis C? Soft lead, soft vel, or GP? So go ahead and put in your responses. We'll give you a few moments. And while we're doing that, I'm going to hand this over to my colleague, Dr. Reau, to get her opinion in terms of how she would approach this and what are the considerations that she would use.
Yeah, so I think that the most important thing is in a person who's got advanced disease and decompensation, and liver cancer would define decompensation. you're going to want to avoid the protease inhibitor. So if you have very well compensated liver disease and you have a HCC, you might make an argument that GP would be an option, but that's probably one that wouldn't be my first choice. Just like soft Velvox would not be my first choice, or anything that had a protease inhibitor in it, or if you're going to try to jerry-rig something together. I think for this patient, you would have to remind me of his genotype, but ladipus, bersofosbuvir, and soft-vel would both be reasonable alternatives. They both have data in decompensated cirrhotics. You might argue that you would consider sofosbuvir or extension of therapy, but I think that unless he's a genotype 3, that both of them would be reasonable.
Yeah, that makes perfect sense. And actually, it's quite interesting that our audience response showed that 60% voted for soft lead and 40% for soft Vel. And I think that's in context of the underlying cirrhosis and arguably the liver cancer, that there was a preference to use a non-PI based regimen here, even though the patients appeared to otherwise have compensated liver disease. So let's go on to look at some of the specific factors in this patient. Now, obviously, there's the cirrhosis factor in determining which regimen may be appropriate, but there's also the concern for drug-drug interactions, right? And so as a friendly reminder, on the bottom of the slide, there is our favorite website that we all go to when we're trying to figure out whether the medications that our patient is taking can lead to drug interactions with DAAs. And this is hep-druginteractions.org, and something that I absolutely look at all the time as I evaluate my patients. In this case, amiodarone actually has a potential interaction with GP, and there's a strict warning against co-administration with both sofosbuvir, velpatasvir, soft-vel, and soft lead. And so in this case, if we're going to treat this patient, we would need to consider either continuing the amiodarone and treating with GP, or switching the patient to a non-amiodarone-based regimen without other drug-drug interactions and using soft-vel or soft lead. And so it's just a friendly reminder that we need to look very carefully at the unique characteristics of the patient and their drug list, both prescribed and non-prescribed, before we make a DAA choice. So this is a slide that briefly summarizes the AASLD IDSA guidance recommendations for the management of Hep C in decompensated cirrhosis. And what we see here is that there are really 3 different groupings. The first are those genotype 1 through 6 who are ribavirin eligible. As a reminder, ribavirin is a very old drug that's been used for several decades that may help to augment SVR and particularly trying to decrease relapse rate after treatment. And so for patients with decompensated cirrhosis, you want to do everything possible to augment their chance of cure as if this is their final chance, right? But ribavirin has potential adverse effects, can cause dry cough, rash, anemia, and many patients with cirrhosis, particularly those with end-stage liver disease, already have baseline anemia and may not be able to tolerate ribavirin. But you want to carefully consider your patient as to whether ribavirin is a realistic choice. But if they are ribavirin eligible, soft Vel plus ribavirin for 12 weeks or soft lead plus ribavirin for 12 weeks are recommended options in this patient population. If they are ribavirin ineligible, then the same regimens are possible, but instead of using soft Vel or soft lead plus ribavirin for 12 weeks, it's soft Vel or soft lead for 24 weeks without ribavirin. And my own experience has been that many of our patients really are on the borderline for being eligible for ribavirin, and often will end up using the soft Vel or soft lead for 24 weeks. And then finally, we have the patients who have already failed a prior DAA regimen. And so for these patients, the AASLD in non-decompensated patients would recommend consideration for either GP if they're genotype 1 or 4, or for genotype 1 through 6, a soft Velvox, sofosbuvir, velpatasvir, voxilavir. But remember, because of the protease inhibitor being contraindicated or relatively contraindicated in decompensated patients, the recommendation here is for soft Vel plus ribavirin for 24, or soft lead plus ribavirin for 24, again, if tolerated. So let's then transition to some patient voice discussion questions. I'll read through these, and then I'll ask my colleague to comment very briefly on how she would advise her patients. So number 1, is it safe to wait on treating my Hep C infection until I'm done with chemoembolization for HCC? I've read online that treating hep C could actually make my liver cancer worse. Is this actually true? And third, is there a preferred treatment option for patients with hep C if they have liver cancer? So Dr. Reau, I'm curious how you would respond to this inquisitive patient.
Yeah, so I think one of the easiest things is to discuss the deferral of therapy until after they're done with chemoembolization. So I usually emphasize to the patient that they've typically had their hep C for decades, and that deferring another month to 12 weeks is probably not going to be nearly as impactful as delaying their cancer therapy, where your cancer can double in size over 3 months. And so you just don't want to defer, prioritization here, cancer first. As to the hepatitis C therapy making cancer biology worse, Joseph, you already talked about that. We don't think that that's the standard outcome, but there are definitely cases where it seems the cancer has become more aggressive in the face of hep C. But more importantly, if it's going to make the hep C treatment less effective, you want to give the person the best opportunity for cure. And so when delay of your hep C treatment is a little less impactful, manage your cancer first and then address your hepatitis C. And as for preferred options, I think that really we have very few options, and you're going to want to pick what's best for this patient. The drug-drug interaction is by far one of the most impactful decision-making. I would say that I would remember or comment that in the package insert for sofosbuvir-containing products, amiodarone is not a listed contraindication, but it is a big warning when the drug-drug interaction suggests that it could be dangerous. And so if you think that the PI is more dangerous and you need to treat, and you're going to treat in the face of amiodarone, this is a time when you need to keep very careful observation of your patient. If you can get rid of the amiodarone and use, the Sofdol without it, that's probably a better alternative.
Great. Thank you so much. I think that's a really wise counsel for our patient here. I'll go ahead and hand this off to my colleague, Dr. Reau, to bring us to the conclusion statements, and then we'll leave a couple minutes for a couple questions that have come through the line.
Awesome. So in conclusion, hepatitis C is still a common cause of liver disease, so please remember the screening. It is associated with significant morbidity and mortality that can be reduced with effective cure. All of our governing bodies really recommend screening universally in those between 18 and 79 or 18 above. And the new addition of hepatitis C screening in each pregnancy is advocated now by not just AASLD, IDSA, CDC, and the United States Preventative Task Force, but also the gynecology and OB obstetric societies. If you are a pregnant woman and you screen positive, you should be linked to care. That does not mean that you have to have significant impact on your pregnancy itself. Patients with hepatitis C in the context of cirrhosis and liver cancer represent careful consideration regarding appropriate treatment and the timing of that. And like this case nicely outlined, you want to make sure that you address the cancer ideally first before you consider hepatitis C treatment. Protease inhibitor-based therapy should be avoided in patients with decompensated cirrhosis, which does include liver cancer. And at the end, all patients with hepatitis C, this was our last case, which we didn't have time for, require hepatitis B serologic testing because there are cases of hep B reactivation. So make sure you get that surface antigen and possibly the core antibody, but definitely do not miss co-infection with hepatitis B with C.
All right. Fantastic. So I think that we have a limited time this evening, but I think there are just two questions perhaps that we can tackle. And so I think the first one was for Dr. Reau. In which circumstances might the benefit of hep C therapy during pregnancy outweigh the potential risks?
Yeah, so I think that this is, twofold. I think the most common reason we consider treatment during pregnancy is if we think that the woman is going to either lose access to insurance or lose access to medical care postpartum. And so at that time, we might initiate treatment at the end of pregnancy and continue it into the early postpartum period so that they can be cured without, having to link to care in a time when they may not have the ability to do that. The obvious time, like Joe, you outlined, is if you have complications of hepatitis C and like vasculitis or something that's very serious. And then I have a woman who actually had 2 children born that had hepatitis C. And so she did not want to mess around when she had her 3rd child. So we treated her during pregnancy because she had a strong risk for maternal to childhood transmission that we couldn't understand. But we wanted to make sure that the 3rd child did not end up with hep C infection.
All right, that's fantastic. So I think there's one question related to our second case, which I'll take, which is there a circumstance when it's prudent to start DA therapy 1 to 2 weeks after HCC complete response? So I do want to be clear from our previous discussion that once HCC complete response has been confirmed, typically 1 to 3 months after treatment with local regional therapy, there is no need to wait further. And so I saw a patient just this afternoon who was now 6 weeks post TACE for a tumor, and it was a little bit bigger than this one. It was just around 3 centimeters, but a single tumor within Milan criteria, and we're ready to go. And so we're going to treat the hepatitis C at this time. But the idea is that you want to confirm the complete response first. And so once that has been confirmed, I don't think there's a need for further delay. Dr. Reau, do you have any other opposing thoughts? Do you prefer to wait longer, or would you be comfortable treating at that time frame?
So I think that anytime you're sure that the cancer is well controlled, you have a patient eligible for treatment. We have not found that delaying treatment so that we can get a hepatitis C positive organ has been that accelerated opportunity to get an organ outside the normal pool. Most of our patients now are very willing to take hep C exposed organs, and despite the overdose death risk, we do not find that Illinois is swimming in hep C positive organs. And so looking at the patient in front of you, I would recommend doing anything you can do to decrease the risk of HCC recurrence, and not worry about the timing of transplant. And I really want to thank Joseph for being a very incredibly easy partner to work with, for the support from Practice Point and our IT support. This has been excellent, and thank you for spending your evening with us.